We are live. Hello, welcome to NEFJC Google Hangout number 3. NEFJC is a Twitter journal club that discusses the latest developments in nephrology in an open public forum. Everyone is welcome, and we've had excellent input from attendings, professors, med students, even patients have contributed. Before we go any further, I want to remind people to sign up for our once weekly email newsletter. We'll keep you abreast of when we're going to have our next chats, when we're going to have Google Hangouts, and we're not going to flood your inbox. We're only going to do it once a week, and we're not going to sell your name or your email to anybody else. Speaking of Twitter chat, we meet every other week to open the discussion on a new topic and then conclude that discussion a week later with a Google Hangout where we summarize the discussion and, if we're lucky, dig a little deeper. This week we are looking at the recently released clinical practice guidelines on diagnosis and treatment of hyponatremia. Joining me today we have NEFJC co-founder Swapnil Hiremath. And we have Hatim Hassan from the University of Chicago. I also want to make sure if anybody has any conflicts of interest, I want people to reveal them. I don't feel that I'm conflicted, but I was a co-investigator for Tempo 3.4, or sub-investigator for Tempo 3.4, which studied tolvaptan and ADPKD. This is a drug that we also use in hyponatremia, though I've never been involved in any of their hyponatremia studies. Swapnil, do you have anything to mention about conflicts?
Thanks, Joel. The only conflict I would say is that I think tolvaptan and baptans in general are great agents. I love using them, and I've used them for hyponatremia. I wish I could use them for PCKD, but otherwise I have no real conflicts of interest. Thanks.
Great. Hassan, do you have anything to add?
I don't have any conflict of interest related to this topic.
Okay, very good. So today's paper is a clinical practice guidelines. These guidelines are not typically the subjects of journal clubs, which usually focus on the primary literature, but these documents are increasingly driving the way nephrologists practice. And so Swapnil and I, we talked about it for quite a while before we decided to pick this article, and we really felt that these documents deserve the scrutiny that research documents get. Nephrology has, of course, played a prominent role in the history of clinical practice guidelines over the years. Everybody's familiar with KDIGO. That was preceded by KDOQI, which was actually preceded by DOQI, which came out in 1997. To kind of rewind our minds back to then, they were recommending targeting of hematocrits in dialysis patients of 33 to 36%, KT over Vs of at least 1.2, URRs of at least 65%, and increasing the fistula rate that was 10% in the United States up to 15% compared to 50% elsewhere around the globe. Also, people were showing up with dialysis units with temporary catheters, and they said we need to stop those. We need to use only cuffed catheters for IJ catheters. And it was a raging success. They met all 4 of those goals. Hematocrit rose from 30% to 34%. That may not have been a wise thing to do, but it was one of their goals. URR rose from 64% to 70%. Temporary catheters fell, permanent catheters rose, and fistula rates increased. Despite the success of those clinical practice guidelines, I know that I was surprised to see a clinical practice guideline. Oh, look who just joined. Dr. Stern of University of Rochester. Dr. Stearns, welcome to the NEFJC chat.
Hi, how are you?
Oh, I'm so glad that you could make it. I'm delighted to have you here. Dr. Stearns, we were just talking about clinical practice guidelines, and I'm going to throw you in there without letting you warm up. I know you were one of the authors on a 2013 paper in the American Journal of Medicine, which was a clinical practice guidelines on hyponatremia. And so I just kind of wanted to get your thoughts on just in general the role of clinical practice guidelines in electrolyte medicine.
Well, I think that they can be helpful. obviously the evidence that we have is far from ideal. We don't have randomized controlled trials to rely on. So it ends up being, I think, an exercise in people who are in trying to make sense out of the available literature in the light of people who've had some experience treating hyponatremia and evaluating it. But I think you have to appreciate them for what they are, and that they are, at the end of the day, a set of opinions by people who hopefully are reasonably informed on the subject.
I think there's no doubt that you would qualify as someone who's regionally informed on the subject. Thank you for joining us. Swapnil, do you have any thought on the use of guidelines in the treatment and management of hyponatremia?
It was actually very surprising that these guidelines came out. We are used to seeing guidelines for disease conditions and not specifically for an electrolyte disorder. And I think this was a great idea of yours to discuss this in a journal club, because it's not just the scrutiny, but I think it's also the dissemination. We should give credit to the European societies, the European Society of Endocrinology, the Intensive Care Medicine, and of course the ERA, the Renal Association, for bringing these guidelines together. But until you notified me on Twitter and you were tweeting about it, I wasn't aware of these guidelines. So part of this journal club is also to help in dissemination to the wider audience, and I think that's a great task.
Hassan, Dr. Hassan, do you have any thoughts here?
No, yeah, I was surprised about the guideline for hyperkalemia, but I don't think it was necessary. But for hyponatremia, I think it's a subject which requires a lot of understanding of the basic law. And I think since, as Dr. Steen said, the evidence is not far from perfect and is merely like observation and depending on expert opinion, having guidelines for hyponatremia is helpful.
Okay, excellent. Swapnil, before we dive in there, can you just kind of give us a summary of the guideline to give people oriented to what we're going to be talking about?
Sure. So the main one of the main key issues, especially with we are talking about the lack of evidence, is that the guideline makers used the GRADE framework. And the GRADE framework is becoming increasingly popular, and I suspect all guidelines will be using it. The KDIGO use the GRADE framework. And in case there's anyone who's not familiar, the GRADE framework has two aspects. There is the number grade, which is either 1 or 2, and there's the letter grade, which is A, B, C, and D. Talking of the alphabetical grade, A, B, C, and D, that depends on the quality of evidence. So, if there's a large randomized controlled trial with and we are very confident about the evidence, then it's an A, and as we become more and more uncertain, it goes down to B, C, and D. With regards to the number grade, one is something like we recommend. The statement comes out as we recommend, and they say that most patients or most physicians will follow that course of action, whereas the number grade 2 refers to the fact that they are suggesting, and some people may choose to go down that path and some people may not. And if you actually look at these hyponatremia guidelines, not surprisingly, given the lack of evidence, most of the statements, most of the recommendations are 2C or 2D. There are some which are, I think the highest grade is 1C, which is not surprising. But as Dr. Hatim and Stearns pointed out, this is an important issue, and even opinions will be very useful. Just to give an overall summary, they do give a nice summary of the pathology of hyponatremia. They are, of course, only talking about the hypotonic hyponatremia and not about the other issues. They go through the biochemical severity, the acuity, and the symptoms of hyponatremia. And again, with the symptoms, they are not going with the classic way of dividing it into hypovolemic, euvolemic, and hypervolemic hyponatremia, which is sort of a departure. They talk about the diagnosis, and we need not go into that in detail. But with regards to the treatment, which I hope we'll discuss in a little bit more detail, they're talking about severe symptomatic hyponatremia, moderate symptomatic hyponatremia, without talking about whether this is acute or chronic. It's only when it goes to absence of moderate or severe symptoms, and they're not calling it asymptomatic, they're calling it absence of moderate or severe symptoms. That's when they divide it into acute and chronic hyponatremia. So that's just a general overview of how the guidelines themselves are framed. Thanks, Joe.
Hey, excellent, excellent. So, Dr. Stern, why don't we just start you? Can you give me kind of your overall view of what these guidelines add, or what are your thoughts on them?
Well, I think that there were some areas where with the European guidelines and the guidelines that the expert panel that I was a part of tend to agree on, and I think that's important. I think that there's been, it used to be very, very controversial that a large increase in serum sodium could be harmful, and I think that's gradually become accepted. And there was, I think there was rather substantial agreement as to kind of that correction ought to be limited in all cases, and limited to about the same degree. There's some minor differences, but I think that was important. I think there are some differences, and the European guidelines took a very strong stand against the use of vasopressin antagonists. I can't say that I'm a strong advocate for their use, but I was surprised at how strong a stand they did take against their use. Why don't we let some other people comment?
Absolutely. Dr. Hassan, do you want to comment on what are your thoughts about the guidelines?
Yeah, I think the diagnostic and the management charts are like nice and logical, and I agree with taking that term of asymptomatic hyponatremia, because studies show that patients presenting to the emergency room with hyponatremia, like a level of 125 and higher, and they have, like, clinically they're asymptomatic, and they were found that they are like 67-fold higher risk for the like falling down, and they have higher risk for falling and bone fractures. So taking that term, I guess, in a lot of patients, when you patient with presenting with asymptomatic, you think asymptomatic. If you do like a battery of like attention test, they do poorly. They have subtle symptoms. So taking that asymptomatic out, that's good. The diagnostic flow chart, it's logical. I like it. I feel comfortable with a limit of 6 to 9 rather than 10. As like we can easily overshoot, and we have to have room for overshooting, and the patient is not like a bus stop. There are too many things going on, so the patient is dynamic. So I will feel more comfortable with a limit of 6 to 9 rather than 10. So you can easily overshoot. I will leave other.
Yeah. About the diagnostic chart, I thought the text that supported that, where they went through all the diagnostic tests and they brought out all the studies on sensitivity and specificity and pointed out all the foibles in terms of physical exam, urinary osmolality, urinary sodium, where they're not as cut and dried. I thought that was excellent. I thought they expressed the subtlety in the diagnosis extremely well. And then they threw up a flow chart that threw all that subtlety out. And I think in the end, so many people will go through these guidelines, they'll look at the flow chart, that's all they'll look at, that's all they'll take with them. And I think that squashes the subtlety in the reality of making these diagnoses. I thought that the text was great, and I think their graphic designer did them a disservice and probably did the other readers a disservice. Swapnil, do you have you mentioned earlier some things about the Vaptans. You use them a lot. You like them. What about that bothered you, that they were so harsh on the vasopressin antagonists?
So among the grading of guidelines, the recommendation, it's one of the highest grade, in fact, that they have in the document. And I've used it a couple of times in the last 6 months. I had great difficulty because of the cost. I had to fight with the administration to get them, but they really work. They are effective, and we used a small dose, just a couple of. So I like them. I understand where they're coming from, but I think it's a very strong recommendation against them. I think used in expert hands, Vaptans may have a role, though I agree you don't want to use them right, left, and center. But I would be interested to know the opinion of Dr. Stearns and Dr. Hassan about the use of Vaptans. The concern is, are they just improving the number?
What?
Well, from my own experience, I can't. Tolvaptan didn't make it to our hospital formula, interestingly enough. Still not on it. And we don't miss it very much. It's rare when we feel a need for a vasopressin antagonist in a hospitalized patient. These patients can be largely managed with hypertonic saline. Where I think they have value, and where we share your difficulty in obtaining them, is in patients with chronic hyponatremia, patients with chronic SIADH, where that's pretty difficult to manage satisfactorily as an outpatient to really achieve normal natremia. And I think as it's been mentioned, there are problems with walking around with a serum sodium of 125 and 130 that we ought to be concerned about. I think if Vaptans cost $1, I don't think there'd be as much talk about whether we should be using them or not. I think the elephant in the room is that the pricing is very difficult to justify in long-term use. It's without having outcome studies. It's pretty hard to hard outcome studies. It's pretty hard to justify that kind of expense.
Excellent. Dr. Hassan, do you have anything to add specifically about the Vaptans?
Yeah, I agree with those.
This is an area that we had a lot of discussion about this. One of the areas that most people were the most interested in during our Twitter chat.
I agree with Dr. Stearns. The cost is prohibitive, like say $300 per tablet. So, and the salt water, and I think the main the concern from the study for the polycystic kidney disease, they use a higher dose. In the salt and water trial, there was no like major complication regarding liver problems. So I think the main problem right now is the cost is very prohibitive. So that might be the problem to use them in like chronically for patients with SIADH or like CHF which are not responding to other modalities.
Excellent. I don't hear anybody bemoaning the fact that they also put a spear through demeclocycline. Anybody missing that drug?
No, I'm not missing it. I agree, because this medication takes days to kick in, takes days to wear off, and it has a lot of nephrotoxicity. I have used it only in one patient with advanced metastatic cancer, and he had like few months to live. And using tolvaptan is like costly, so we used it and it was working fine for him. But I guess generally I agree for like not including it.
Yeah, we're getting to the time of year where it's important, if you do have people on demeclocycline, remind them to use sunscreen or avoid the sun entirely. That can cause a nasty sunburn. It looks like Dr. Stearns has seen that occasionally, just judging from his reaction.
Well, I agree. I think there's it's also costly, demeclocycline, and it's a far inferior drug. I think for the reasons that have been stated, that you're giving a patient another disease, nephrogenic diabetes insipidus, and that doesn't wear off. This is often a fragile population, and to then have patients who have to replace their water losses when they're ill, and they're going to have nephrogenic DI for days. I think the nephrotoxicity is a problem. I think the photosensitivity is a problem, and the expense is a problem. I think that drug belongs as an historical memory.
Very good. So the guidelines are almost entirely either ungraded or D-level evidence. And so I just want to get a thought from the panel here. You know, why is that? This is a very common disease. Why is the evidence so thin? Dr. Stern?
Well, no, that's a good question. I think it's a sad commentary on our discipline. It's a shame that these are it's relatively rare to encounter patients with very low serum sodium concentrations in the hospital, and so it requires a multi-center study. And I think there just hasn't been the organization or the funding to do that. Nowadays, I think you have to have a drug. I think, unfortunately, the studies of vasopressin antagonists that were used, and the only multi-center studies that we had, treated people with serum sodiums which were barely below normal, and not the subject of all the controversy that people are living with. So, I think basically there's no sponsor. We need multi-center trials. I think there would have been ways to do that as a society with voluntary participation in a multi-center effort to see. To keep track of what we're doing, but we haven't done that. It's a shame.
Dr. Hassan, can you make some comments about the evidence?
I think Dr. Sten said it well. I don't have anything to add. He's an international authority in this area, and he has done a lot of research. So I agree with what he said.
Higher math, anything else?
Yeah, Dr. Stearns pointed out, it's mainly many studies are often driven by industry, and the only few randomized controlled trials we have come from the manufacturers of the Vaptans. To do any such study in hyponatremia with, say, hypotonic saline would require NIH funding and a champion to do that, and that's notoriously difficult. So, it's okay to say that, yes, we have failed, but it's also the lack of industry support.
I don't know. Morton Salt, I'm looking at you guys. When I read the guidelines, I thought I found every important paper that I'm familiar with on hyponatremia. And when you do go through these guidelines, what they don't cover is as important as what they do. And I was wondering, is anybody aware of what they thought was a pretty significant paper that didn't make the guidelines either intentionally or accidentally? Swapnil?
No, actually, I'm not an expert on hyponatremia at all, and I found the guidelines to be a very exhaustive, very meticulously written. It's a document that I think I'll refer to in clinical practice for a long time.
Great. Dr. Stearns?
You're testing my memory. In the European guidelines, I don't know if they mentioned there was a trial by, I think the first author's name is Wu, and it was a single center study, a cohort study in patients with severe hyponatremia, and it was an outcome study, and I think it reinforced other studies. And my recollection is that wasn't included. What actually was more surprising to me from the European trial, European guidelines, is they had this very rigorous process of obtaining data. And if you'll notice, one of their strongest statements is that the risk of acute hyponatremia exceeds the risk of rapid correction of hyponatremia. I guess that might be true, but they offered absolutely no evidence in support of that. There really aren't even, observational cohort studies. They're really kind of collections of anecdotes as bad outcomes from acute hyponatremia. And this was, I think, an acceptance of conventional wisdom. Conventional wisdom is often correct, and I certainly don't dispute that people with acute hyponatremia ought to be treated aggressively. But they actually said that if somebody's vomiting, this ought to be treated as a hyponatremic emergency, And I'll tell you that an awful lot of people with severe chronic hyponatremia are vomiting. It's very, very common, and I don't think they're in the process of herniating.
Dr. Hassan, any articles or studies that you think are important that weren't covered in the guidelines that you're aware of?
Yeah, I think they did a pretty good job. I think I don't remember whether they included Dr. Sten was talking about the Hellwig study about the patient from 1938 with acute hyponatremia, and he was rescued by like 130 mLs of 5% saline, which is equivalent to 200 ml of 3%. But otherwise, I think they did a pretty good job in covering most of the literature.
Okay. Last thing I want to ask you guys is, what do you think is the most pressing research need in hyponatremia? In the kind of the nephrology social media space, we have this concept called the DREAM RCT. What would be the study you would do if the NIH dropped a few $1 million off at your door and said, push back the walls of knowledge in hyponatremia? Let's start with you, Dr. Stearns.
Well, I think, again, going to this premise that if the vasopressin antagonists cost $1, we'd be using them a lot. That one of the things that I think is needed for their use is to establish an antidote, a way of stopping a water diuresis triggered by a vasopressin antagonist. You'd like to know what dose of desmopressin, for example, would stop a water diuresis from a vasopressin antagonist. I think that there would be the potential of using these drugs, I think once the patent wears off, runs out rather, to use these in a titration way, and really need to know if a patient were on desmopressin, for example, could you give a dose of vasopressin antagonist to overcome the antidiuresis, and then vice versa to overcome the aquaretic effect of the vasopressin antagonist with desmopressin. That's my dream study. I think it would offer the opportunity to very closely titrate the rate of correction of hyponatremia in a very controlled way.
Excellent, excellent. Dr. Hassan, what would be your dream RCT?
I think it's like a multi-center, high-quality study comparing like the vasopressin antagonist, and the way especially the issue of this re-lowering of sodium if you are overcorrecting. We have strong study perspective about looking into this issue in more detail, because right now we can easily overshoot, and there are Dr. Sten has some data in animals and some human about re-lowering the serum sodium. So if we can study more of this in more detail, that would be very helpful about the way of how to overcorrect.
Excellent, excellent. I think at my dream RCT, if I was able to do that, I would want to look at these mildly asymptomatic patients with sodiums in the 126, 128 region. Do we have real benefit from correcting their sodium, getting those patients' sodiums up? Does it make a whit of difference? There's a kind of a dogma in the hospital. We can't discharge people with sodiums less than 130. We see the fall data, but we don't have an ability to complete the loop and know that fall risk goes away with correction of sodium. And so that's what I would study. Looks like Swap Mill might be back. Harmath, you there? Maybe not. Okay, you've been having some technical problems.
Wait, Joel, I like your study. I think, particularly in geriatric populations, we know that people fall, but what's really needed is the demonstration that if we maintain them at normal serum sodium concentrations, that their fall risk goes down and their fracture risk is reduced as well. So I agree with you.
Excellent. So, we're going to wrap up the hyponatremia section right now. I just want to, do you guys, either of you have any final thoughts you want to leave us with? And then we're going to kind of talk about our next journal club. Dr. Stearns?
Well, no, I think that we've come a long way. I think we can bemoan the lack of controlled data, but I think the interesting thing is that we have some fairly consistent observational studies that they're supported by animal experiments, and overall these the years that we've been working with these, I don't think we've seen evidence emerge that our current practices are incorrect. So we have what we have, and I think it's important for people to report when there are evidence, if evidence emerges to show that what we're doing needs some fine tuning.
Excuse me, I'm sorry, Dr. Hassan, do you have any final thoughts? Dr. Hassan, you there? Do you have any final thoughts on the guideline? Okay, we might have lost him. Swapnil, do you have any final thoughts on the hyponatremia guideline for us?
Yeah, I just got disconnected also, but I just saw a question on Twitter.
We don't hear him either.
Yeah.
Okay.
Yeah. Can you hear me?
Oh yeah, so Dr. Matt Sparks would like to ask
Yeah.
Dr. Stearns if any major studies are underway to study correction of chronic or acute hyponatremia.
I didn't understand the question. I'm
So
sorry.
he says, are there any major studies that are underway to study correction of chronic or acute hyponatremia at this point?
Not that I'm aware of.
That's too bad. Rather depressing. I'd like to thank both you guys for joining us. The only thing we're going to do right now going forward is we're going to announce the next NEF-JC topic for next Wednesday night. Thank you for joining us. This has been an absolute pleasure. Really, you guys did a great job. Thank you very much for coming on.
Thank you, Joel.
Thank you, Joe. Thank you so much.
So,
thanks, Rob.
Our next Wednesday night, we're not doing it on Tuesday because it's my anniversary, my 14th anniversary to my lovely wife. So next Wednesday at 9 o'clock, we're going to be discussing the Poseidon trial. The title of the trial is the Hemodynamic Guided Fluid Administration for the Prevention of Contrast-Induced Acute Kidney Injury. The Poseidon randomized controlled trial, it's in the Lancet. There'll be a link up on NEF-JC tomorrow. Essentially, this is an interesting attempt to add some intelligence to the way that we hydrate patients undergoing contrast for heart catheterization. It is a positive trial. It will be a long time. Well, we do some negative trials. Swapnil, do you have any thoughts on the Poseidon, just kind of to get us started?
Can you hear me now?
Yeah, look, I can hear you now.
Okay, excellent. So yes, it's a positive trial, but as Tejas and others may point out, it actually was done by cardiologists, which is interesting. I think cardiologists are more successful than we are. So
Okay.
let's leave it at that, and we can have. I think we'll have a great discussion next Wednesday.
Yeah, I think we'll have to get some of the cardiologists involved there. They box enough kidneys. They should spend some time talking with us. Hey, thanks a lot for joining the NEF-JC Google Hangout. This is Joel Toff and Swapnil Hiremath signing off. You guys take care.
Thank you.
Bye.